Right. Hi, everyone, and thank you for coming back for another 1 minute consult. Today, we have the privilege of going live with Dr. Joseph Coselli. He's the Executive Vice Chair of the Department of Surgery, as well as the Cullen Foundation Endowed Chair and Professor of the Division of Cardiothoracic Surgery at Baylor College of Medicine. Welcome, Dr. Coselli.
That was great. Great to be with you again. And what I want to do here is briefly go through technically how we carry out extensive thoracoabdominal aortic aneurysm repair, specifically the extent twos, and build into that a little information on why we choose some of the adjuvants that we do. So we start out with a problem like this, extensive thoracoabdominal aneurysm. Crawford extent 2 from the left subclavian to the aortic bifurcation. And we want to end up with a anatomic reconstruction with patent intercostal arteries, visceral and renal vessels. So this is also an intraoperative picture of the mid portion of one of these repairs. So we do this with a double lumen bronchial tube so we can selectively not ventilate the left lung. We use fixed retractors and a thoracoabdominal incision. Patients position in a right lateral decubitus manner, and we sort of flex things so that the shoulders are at about 60 degrees, the hips are about 30 degrees. Most of the time, I will as well divide the diaphragm in a circular fashion, and I usually go intraperitoneally, or not always. And so this is what this looks like with a patient prep draped and in the proper position, and this is how this looks with the thoracoabdominal incision, usually through the sixth rib. We'll sometimes divide the neck of the sixth rib to get a little additional exposure. We try to preserve as much diaphragm as possible, and we used a set of fixed retractors. We then place these patients on a left heart bypass using oxygenated blood from the left atrium and then perfusing it in distally. We used to use the femoral artery a lot, but more often now we'll cannulate the aorta at the level of the celiac axis using intraoperative and preoperative CT or MRI scanning to identify an area where we can cannulate and not dislodge any thrombus. We run these flows ultimately dependent upon balancing pressures with anesthesia. We like to keep a proximal pressure of at least 70 millimeters of mercury mean, as well as a 70 millimeters of mercury distally when those pressures are measured. So this is just going to be a brief overview, but then what we do is we cross clamp the aorta and open up the mid portion of the aorta, perfusing distally. What you're looking at here is after we've opened up the entire aneurysm. So we've carried out the proximal anastomosis, and then we've selected an appropriate graft. And in this drawing, we're reattaching intercostal arteries, which is the next step. During this period of time, we're perfusing the celiac and the SMA with the left oxygenated blood from the left atrium through a centrifugal through the closed circuit, and use a cold crystalloid solution to cool down and preserve kidney function. So this is what this looks like after we've reattached the intercostal arteries. We'll do the distal anastomosis. We're still protecting and perfusing the visceral and renal vessels. And once we open up to the legs, and this opening up to the iliac arteries is part of our spinal cord preservation techniques, because the internal iliac arteries certainly contribute to that. And then we'll stepwise begin to reattach the visceral vessels with these branches off of the main graft. Usually the right renal first, followed by the celiac and the SMA, or if we have poor renal function, we'll do the right and left renal first and then do the visceral vessels. And this is what this ends up looking at. More often than not, I'll mobilize the left renal artery extensively so that we can keep that graft to it fairly short. The grafts to the celiac and the SMA are 10 millimeter grafts. The grafts to the renal arteries are 8 millimeter grafts.